Margaret was 71 years old when she walked into her doctor's office for what she called a routine checkup. She felt fine. She slept well. She walked 2 miles every morning and ate what she believed was a sensible diet. Her blood pressure reading that morning was 142/88. Her doctor looked at the number, looked at her, and said, "We need to start you on medication." Margaret asked why. Her doctor said, "Because the guidelines say so." She went home with a prescription she did not understand for a condition she was not sure she actually had. 3 years later, she was on 2 blood pressure medications, a diuretic and a statin. She was dizzy by noon every day. She had stopped her morning walks because she was afraid of falling. She told her daughter she felt like she was disappearing. That is when her family brought her to me. What if everything Margaret was told about blood pressure after 60 was built on guidelines designed for a different body than hers? Stay with me. Because what you are about to hear is not taught in most doctors' offices. It is not printed in the pamphlets they hand you at checkout. It is the information that lives in operating rooms, in peer-reviewed journals that most patients never see, and in the quiet conversations surgeons have with each other when the waiting room doors are closed. After more than 3 decades opening chests and holding beating hearts in my hands, I have seen what blood pressure actually does to the body from the inside. And I am telling you right now, what you have been told about blood pressure after 60 is incomplete at best and dangerous at worst. Today, I am going to show you 5 things about blood pressure after 60 that your doctor may never have mentioned. These are not opinions, they are mechanisms. And once you understand them, you will never look at that cuff reading the same way again. Before I tell you what those 5 things are, I need to tell you who I am and why that matters. I spent 31 years as a cardiothoracic surgeon, more than 2,000 open heart procedures. I have repaired aortas that had been silently expanding for a decade, while their owners were being told their blood pressure was a little high but manageable. I have operated on patients whose medications had done exactly what they were designed to do, and whose hearts were still failing. I have also seen patients walk away from numbers that looked terrifying on paper because they understood what those numbers actually meant for a body over 60. The medical system is not corrupt, but it is built on efficiency, and efficiency means guidelines. And guidelines, my friends, are written for populations, not for people. Here is what nobody tells you. The guideline that says your blood pressure should be below 130/80 was not derived from studying people over 60 as a distinct biological group. It was extrapolated, and extrapolation in medicine carries a cost. Now let me explain why the body after 60 is not simply an older version of the body at 40. This is the foundation. Without it, nothing else I tell you today will make complete sense. Think of your arteries as rubber garden hoses. At 30, those hoses are flexible. When pressure surges through them, when you stand up suddenly, when you exercise, when you laugh hard, they expand and absorb that surge. They are elastic. They buffer. But after 60, something changes. The walls of your arteries begin to stiffen. The elastin fibers that gave them their spring start to break down. Collagen, a stiffer, less forgiving protein, begins to replace them. The hose becomes less like rubber and more like a slightly rigid plastic pipe. Now, when pressure surges through that pipe, there is less room for error. The pipe pushes back, and here is the critical part. A stiffer artery requires a higher pressure to push blood to the organs that need it. This is not pathology. For many people over 60, a reading that would be alarming in a 40-year-old is the body doing exactly what it needs to do to keep the brain, the kidneys, and the heart itself adequately perfused. One study published in the Journal of the American Medical Association followed nearly 5,000 adults over the age of 65. It found that in adults with a history of dizziness or falls, aggressive blood pressure lowering was associated with significantly higher rates of fainting, injury, and cognitive decline. The medication was working. The blood pressure was lower, and people were getting hurt. That is the paradox nobody explains to you at the pharmacy counter. Now, the 5 things. The first thing you need to understand is what your bottom number actually means, and why it is the number most people over 60 should be watching far more closely than the top one. Most people, when they hear blood pressure, focus on the systolic number, the top one, 140, 150, 160. That is the number that gets the concerned look from the nurse. But after 60, the number that tells the most important story is often the diastolic pressure, the bottom one. Here is why. Diastolic pressure is the pressure in your arteries when your heart is resting between beats. It reflects how much resistance your arteries are offering, even when they are not being actively pushed. In younger people, a high diastolic number is worrying because it suggests the heart is working too hard during its own rest phase. But in people over 60, the picture often reverses. The diastolic number can actually be too low. And a diastolic reading that drops below 60 in a person over 60 is not a sign of good control. It is a sign that the brain and the kidneys may not be receiving enough blood between heartbeats. I have seen this pattern in the post-operative recovery room more times than I can count. A patient comes out of surgery with a blood pressure of 118 over 54. The nurses are pleased. The systolic is perfect, and I am watching that diastolic number with everything I have because I know what too low diastolic means for a 73-year-old heart. Write that down. Ask your doctor not just what your systolic reading is, but whether your diastolic is staying above 60. That one question could change your entire treatment picture. The second thing, and I want you to stay very close to this one, is the phenomenon of white coat hypertension and its hidden counterpart that almost no one talks about. White coat hypertension is well known. You sit in a doctor's office. You are anxious. Your blood pressure spikes. The doctor sees a high reading. You are prescribed medication for a blood pressure that, in the rest of your life, is perfectly normal. Studies suggest that somewhere between 15 and 30% of people diagnosed with hypertension in clinical settings have white coat hypertension. That is not a small number. That is a substantial slice of people who may be taking medication for a condition they do not have outside that particular chair. But here's what nobody tells you about the counterpart: masked hypertension. This is the reverse situation. In the doctor's office, you are calm. You sat down for 10 minutes before the reading. Your number looks fine. But at home, during your regular activities, walking to the kitchen, having a stressful phone call, climbing a flight of stairs, your pressure spikes into ranges that would concern any cardiologist. Masked hypertension is, if anything, more dangerous than white coat hypertension because it is invisible to the standard screening system. A person with masked hypertension is told they are fine. They go home feeling reassured. Their arteries are experiencing pressure spikes that the office visit never captured. If you are over 60 and you have any symptoms that feel unexplained, headaches in the morning, mild confusion after exertion, occasional pressure in your chest that resolves quickly, I would encourage you to ask your doctor about ambulatory blood pressure monitoring. That is a small device you wear for 24 hours that captures your blood pressure throughout your real life, not just in the examining room. That data is worth 10 office readings. Now I need to pause here for a moment because what I am about to tell you in item 3 is the piece of this conversation that I believe is most consequential. And before I get to it, I need to ask you something. How many medications are you currently taking for blood pressure? 1, 2, 3? Because the answer to that question and the specific combination of those medications may be more important than the number on the cuff itself. The third thing, and this one should fundamentally change how you think about your treatment, is the concept of medication-induced hypotension in motion, not at rest, in motion. Your doctor measures your blood pressure while you are sitting still. The medication is calibrated to that measurement, but you are not always sitting still. You stand up from a chair. You walk to the bathroom at 2 in the morning. You reach up to a shelf, and in those moments, your blood pressure system has to rapidly adjust to gravity, to movement, to the sudden demand for more circulation in your legs. In a younger body, that adjustment happens quickly and smoothly. In a body over 60, especially one on blood pressure medication, that adjustment can fail. The medical term is orthostatic hypotension, a sudden drop in blood pressure upon standing. The lay term is, the room goes gray, you grab the nearest counter, and if you are unlucky, you go down. The statistics here are not comforting. Falls are the leading cause of injury-related death in adults over 65. And orthostatic hypotension, often directly tied to blood pressure medication, is one of the most common contributors to those falls. I am not telling you to stop your medication. I am telling you to ask your doctor whether you have ever been tested for orthostatic hypotension. The test is simple. Blood pressure lying down, blood pressure after standing for 1 minute, blood pressure after standing for 3 minutes. If your pressure drops more than 20 points systolic or 10 points diastolic, you have a clinically significant response that warrants a medication review. Ask for that test, starting tonight. Pay attention to how you feel when you stand up. That sensation of brief lightheadedness is not nothing. It is data. The fourth thing is about sodium. And I promise you, what I am about to say is going to sound like heresy, and it is completely supported by the current evidence. You have been told to reduce your salt intake. That message is so universal, so deeply embedded in public health culture, that questioning it feels almost irresponsible. But here is the nuance that the public health message almost never delivers. Sodium sensitivity is not universal, and in adults over 60, the relationship between sodium intake and blood pressure is far more individual than the standard advice suggests. A landmark review published in the Cochrane database examined the evidence for salt restriction in people with normal blood pressure. The review found that moderate salt reduction produced only modest blood pressure reductions in most people, and in some individuals, particularly older adults with certain hormonal profiles, aggressive salt restriction was associated with increased cardiovascular risk, not decreased risk. The mechanism involves a hormone system called the renin-angiotensin-aldosterone system. When sodium drops too low, that system activates to compensate, and its activation, the release of angiotensin and aldosterone, can drive cardiovascular strain that offsets any benefit from the lower sodium intake. This does not mean salt is harmless. It means that blanket dietary advice applied without individual testing may not be serving you the way you have been led to believe. Ask your doctor whether you have ever been assessed for sodium sensitivity. A simple low-sodium dietary trial monitored with home readings can give you real, personalized data. Your body deserves that specificity. The fifth thing is perhaps the most underappreciated finding in cardiovascular medicine in the last 2 decades, and it has to do with the relationship between blood pressure and the brain, specifically with what happens to cognitive function when blood pressure is lowered too aggressively in people over 70. The brain is the most blood-hungry organ in your body. It represents about 2% of your body weight and consumes roughly 20% of your cardiac output at rest. It is extraordinarily sensitive to changes in perfusion pressure, the pressure at which blood is delivered to it. And after 70, the brain's ability to auto-regulate, to maintain stable blood flow across a wide range of pressures, begins to narrow. In younger people, the brain can maintain stable blood flow at systolic pressures anywhere from roughly 70 to 170. In many people over 70, that auto-regulatory window is narrower and shifted upward. The brain has adapted to function at a higher baseline pressure. When medication brings that pressure down sharply, the brain can lose adequate perfusion. The early symptoms are subtle: slight memory lapses, mild confusion, fatigue that does not respond to rest, a feeling of being mentally slower than usual. These symptoms are often attributed to aging. They are sometimes caused by treatment. A paper published in JAMA Internal Medicine followed adults over 75 who were treated to a systolic target below 120. The researchers found higher rates of cognitive decline in the intensively treated group compared to a group treated to a target of below 140. The brain was not better protected by the lower number. It was, in some measurable ways, less protected. Write that down. If you are over 70 and you have noticed any changes in memory, clarity, or mental energy since starting or increasing blood pressure medication, that observation is worth bringing to your cardiologist. Do not dismiss it as aging. Bring it as data. I want to stop here and tell you something I have never found easy to say out loud. I have stood at the head of an operating table in a room that smells of antiseptic and quiet machinery, and I have repaired damage that was years in the making. The artery that finally gave way had been under siege for a decade. The valve that was failing had been straining against pressures that were managed, technically, but perhaps not well enough, or perhaps managed too aggressively in a different direction. And every single time, somewhere down the corridor, a family was sitting in chairs they did not want to be sitting in, holding paper cups of terrible coffee, waiting to hear something. These were not people who had been careless. They had gone to their appointments. They had taken their pills. They had done what they were told. And what stayed with me, what has never left me, was the ordinariness of the habits that had preceded the crisis. The dizziness they had mentioned in passing and been told was nothing. The fatigue they had attributed to getting older. The reading that looked fine in the office and was something different at home. These were not dramatic warning signs. They were quiet signals in a language nobody had taught them to read. That question has stayed with me. How do I reach people before they are in my operating room? And the answer, I have come to believe, is this conversation, right here, right now, with you. I think of Margaret. 3 months after she came to me, we had completed a full ambulatory monitoring assessment, a medication review with her cardiologist, and a frank conversation about her diastolic numbers, which had been hovering in the low 50s for nearly a year. Her medications were adjusted, not eliminated, adjusted. Her morning dizziness resolved. Her walks returned. At her 6-month visit, she was on 1 medication instead of 3. Her blood pressure was 136/68. She was not at a textbook number. She was at her number. The pressure her body needed to feel and function well. Her daughter called me on a Tuesday afternoon just to say that her mother had made pie that weekend. She had not made pie in 2 years because the dizziness had made her afraid to stand at the counter that long. Margaret said something at that last visit that I have not forgotten. She said, "Nobody ever told me it was this complicated. They just told me the number was too high." That sentence is why I am here talking to you today. Let me give you the 5 things one more time, clearly and quickly. 1. Your diastolic number matters as much as your systolic, and if it is dropping below 60, that warrants an immediate conversation with your doctor. 2. White coat and masked hypertension are both real and both common, and a single office reading may not accurately represent your actual pressure throughout your day. 3. Medication-induced drops in blood pressure upon standing are a leading contributor to falls, and you should ask to be tested for orthostatic hypotension if you have never been evaluated. 4. Sodium sensitivity is individual, and aggressive blanket salt restriction may not benefit you and may in some cases carry risk. Ask for personalized assessment. 5. Aggressive blood pressure lowering in adults over 70 has been associated in multiple studies with measurable cognitive effects. If you have noticed changes in mental clarity since starting or adjusting medication, report it, document it, and insist that it be taken seriously. Now I want to ask you something personal. Of these 5 things, which one surprised you the most? Drop it in the comments. Tell me which number. Tell me why. I read every single comment, and your answer will help me understand what information is most missing from the conversations people are having with their doctors. If someone you love is over 60 and navigating blood pressure treatment, share this video with them. Not because I have all the answers, but because they deserve to walk into their next appointment with better questions. Questions are not defiance. Questions are the beginning of real care. And if you have not subscribed yet, I want you to do that now. Because every week I am bringing you the information from inside medicine that you were never given in the waiting room. Information that belongs to you. It is never too late to understand your own body. It is never too late to ask a better question. And your heart, your extraordinary, tireless heart, has been working for you every single minute of your life without a single day off. It deserves the most accurate information you can give it. One final word before we close. I am a surgeon, and the information in this video is drawn from decades of clinical experience and peer-reviewed research. It is intended to inform your conversations with your own physician, not to replace them. Every person's cardiovascular profile is different. Please do not adjust or discontinue any medication without consulting the doctor who knows your complete history. What I am asking you to do is not to distrust your doctor. I am asking you to walk into that office better prepared, better informed, and more willing to say, "Tell me more." That conversation, the one between an informed patient and a physician who respects them, is where the real medicine happens.